We're going to continue now with Dr. Mohammed SAMIR, who's going to be talking about macular buckling, different techniques.
Okay. I'm talking today about macular buckling, different technique. In high myopic eyes, the axial elongation of the eye is a very challenging condition, and the development of the posterior staphyloma results in thinning of the retina and choroid, which lead to myopic maculopathy. As we see here, fundus photography taken by Optos, in which the upper edges of the staphyloma is pigmented in the pseudo-color images with granular hypoautofluorescence. And as we're going to see in the next slides, the effect of the posterior staphyloma and the myopic traction maculopathy. The myopic traction maculopathy is a wide spectrum of clinical pictures that may affect up to 30% of eyes with pathological myopia, with and without posterior staphyloma. We have different classification. We have the old classification, myopic fovascitis, partial thickness macular hole, full thickness macular hole retinal detachment, and the last and the recent classification of Barbara Parolini, which is addressing the tangential and the anteroposterior traction elements. The mechanism of myopic macular hole retinal detachment in these cases is due to the tangential traction on the macular surface and anteroposterior vitreoretinal traction and the reduced retinal adherence because of the atrophy of the RPE. So this is the first case in our series, 46 years old patient with myopic hole retinal detachment due to high myopia. We used in this case the what's called endoplumb, or the macular plumb and the macular buckle. As we're going to see, we put 18 millimeter from the limbus staying suture, 7 millimeter apart, and taking the stay sutures in the sclera and putting the endoplumb, which is the macular buckle we are speaking about, or addressing in our presentation. It is malleable. It is flexible. It has a titanium wire inside, so it has a good memory. And after we put it, we inject. We don't do vitrectomy in these cases. We don't enter inside the vitreous. We don't put silicone or something like that. And this is the result. This is the second day post macular buckling. This is an air bubble. We put it to get the pressure of the eye within normal. It succeeded, but unfortunately, after 5 days, we have a recurrence. What is the cause of this recurrence? The cause of this recurrence is that the endoplumb, the end, is not actually on the hole. This is the indentation part of the plumb. So we make what's called a modification in this endoplumb, while putting a fibro light in this plumb at the end of the plumb, 23 gauge or 25 gauge light. This light, while using it during the operation, I will fix it in the right way at the posterior pole, or at the right way at the macula, so increasing the incidence in this in the success rate of these cases, as we are going to see in the video. Putting the plumb like that and entering, seeing through the indirect ophthalmoscope or even the microscope, the indentation light, as we are going to see in this video, and putting the indentation light at the proper area, which is at the macular hole, myopic macular hole, to buckle this myopic macular hole and to configure the posterior aspect of the globe. And this is the most strong point in treating the posterior staphyloma in myopic traction maculopathy is conforming the posterior pole configuration by using the macular buckle. After that, we inject air bubble to conform the globe. And as we are going to see now, taking the stitches, the last stitches, and this is the successful indentation, the macula in place. And this is 1 week post-operative OCT. mild fluid around the myopic macular hole, and we are seeing also the closure of this macular hole in this slide. This is after 1 month, no fluid, and the macular hole closed, and this is our paper. The last slide, there is a new what's called titanium buckle by our friend Akduman. This is a titanium, totally titanium buckle. This is, as we see here, myopic traction maculopathy case, putting 17 millimeter from the limbus, taking the stay suture as we are watching the video, and starting to introduce the buckle. This buckle is very, very hard. It's not flexible like the end plumb, but it has a good results. It causes a good and strong indentation effect at the posterior pole, as we are going to see now in this part of the video. This is the buckle. It has 2 knobs at the anterior part to be fixated, putting it, and we can manipulate it while using, as we are going to see in the video, a chandelier light, and I can see the indentation effect of this buckle, and adjusting the plate of the buckle at the posterior pole, as we are going to see in the video. It doesn't need a long learning curve from the surgeon, but it needs to be oriented with the anatomy of the posterior pole and the posterior staphyloma, as we are going to see here. This is the indentation effect of the buckle. This is the indentation effect of the buckle, and I'm using this indentation to move it to accommodate the staphyloma at the posterior pole and at the macular part, as we are going to see now. So moving the buckle and adjusting its place while putting the chandelier light, as we are going to see now. It's not a hard procedure, or it's not a difficult procedure, but it's important to put it in the right way. After that, we are going to take the sutures and to fix it and close the conjunctiva without doing vitrectomy. We don't enter inside the eye. We don't remove the posterior hyaloid. We don't be confronted with iatrogenic breaks or iatrogenic macular hole. And this is the indentation of the buckle, and this is our sign of success. And it was nice that we just has published this procedure in last February. Thank you very much.